So this class will continue on health-related and clinical exercise testing. We'll talk a little bit about cardiac rehab and emergency procedures. So whenever there is, say, an athlete or a young person who dies from sudden cardiac death, a lot of people will say, well, why don't we just screen everyone for heart disease, and then we'll detect, all these people who could have been saved from sudden death. Well, logistically, it's not possible to screen the entire population. We just don't really have the ability to do that. But there are some issues with testing, sensitivity and specificity. So sensitivity, we want to be able to pick up those people who actually have heart disease. So they show changes on the Bruce protocol with ECG monitoring, and that's called the graded exercise test, or GXT. And so those are the people that we correctly identify that have heart disease. And then specificity is the percentage of people who don't have heart disease and they don't show changes on their ECG. So we want to be able to correctly identify people. So if we screen the people who really need to be screened, then we're going to have good sensitivity and specificity. So sensitivity, the true positive test. So a person who has ST segment depression on their ECG that indicates ischemia, then they're going to go on and have further tests, and that's going to indicate that they have heart disease. So that's good specificity. There is also the chance that we could have what's called a type 2 error, or false negative. Some of you might remember this from research methods. So these are people who show no diagnostic ECG changes, and so these are people that we miss. They actually have heart disease and we weren't able to detect it with testing. So we want to be able to correctly identify those people who do have heart disease, and we don't want to miss the people that actually have heart disease, because that can happen as well. How good is exercise testing at predicting heart disease? So we want to, by testing the right people who need to be tested. So based on the prevalence of heart disease in the population being tested. So we want to correctly identify, be able to predict heart disease in people who may actually have heart disease. And this box looks confusing. It's not that difficult if you really go through it. Again, sensitivity. So the patient, so the true positive. So the true positive test, so those are people who actually have heart disease and had a positive test, divided by the true positive plus the false negative. So the percentage of people with heart disease who had a positive test. So they did initial screening with the GXT, and it turns out, yes, they do have heart disease. Specificity, the people without heart disease who have a negative test. And then how can we get the predictive value of positive and negative tests? There can be people who have false positives. So type 1 error, saying that you have heart disease. So for example, someone could have ECG changes that might indicate ischemia. They're going to go for further testing, and then ultimately it shows that they have no heart disease. And this is more so in women than men. Women tend to show more false positive on the Bruce protocol stress test in looking at ischemia. So we want to be able to identify the people who have heart disease, correctly screen out people who do not have heart disease, and be able to have a good prediction of people who likely have heart disease and those who do not. And so why would people not, have a false negative test on their graded exercise test? Maybe they didn't reach the point of the test where they have myocardial ischemia. For example, maybe the test was terminated at 85% and it wasn't really a max test, and they're going to show their symptoms at a much higher intensity. Maybe the ECG monitoring wasn't good. So you want to, once again, get that good prep like we did in lab the other day. Maybe people missed other symptoms such as blood pressure changes or signs or symptoms that the client might be showing. The next bullet's kind of interesting, collateral circulation. So the person might actually have major heart disease and their vessel might be blocked, but they developed their own little network of vessels around that, so they're not getting the chest pain type of symptoms. Musculoskeletal limitations, these are people, say for example, you had to stop the exercise test because their knee or their ankle or their back was hurting. So you weren't able to get to an intensity high enough to elicit ischemia. And of course, there could be technician error, observer error, equipment error as well.